Hi, my name is Paige Stinson, and today we're doing a hip assessment. Our client has completed a PAR-Q form, which can be seen on the right. Client history, they were a competitive swimmer for 10 years with an emphasis in breaststroke events. At age 6, they pulled their groin with their first hip injury, and then at age 15, they progressed to physical therapy interventions for hip impingement symptoms. And then over the course from ages 15 to 20, they have had 3 groin pulls, and now currently they sit with malalignments in their flexors, adductors, abductors, and internal and external rotator muscles.
So for static posture analysis, on the anterior side, we see that she has her right foot slightly forward, which can be caused to help alleviate discomfort or pain that is caused by the tight right hip. In her posterior side, she has higher hip pike on the right side, which can indicate a potential imbalance or tightness in the muscles around her pelvis, and hip can be caused by tight hip flexors, tight quadratus lumborum, or gluteal muscles. Some overactive muscles could be the iliopsoas, rectus femoris, tensor fasciae latae, or her adductors, and some underactive muscles could be the gluteus medius, the gluteus maximus, and the external rotators.
All right, my name is Peter Bengal. I did the translation movement assessments. So for the overhead squat assessments on the anterior view, first thing we can see is that there's everted feet. This can be caused by muscles such as overactive soleus, lateral gastroc, short head of the biceps, and the TFL. For the underactive muscles, we have the medial gastrocs, the medial hamstrings, the gluteus medius and maximus, and the gracilis. Also the sartorius and everything that externally rotates is typically underactive when we see those feet everted. In the lateral view, we have some forward trunk lean. This can once again be caused by overactive soleus and gastrocs, hip flexors, piriformis, and some rectus abdominis and other abdominal muscles. Underactive muscles would be the anterior tib, the glute maximus, and the erector spinae. The last thing we see, as there's not too much in the posterior, but the last thing in the lateral view is the arms do slightly come forward. This is often just due to the tight lats, major and minor, and as with a lot of people, underactive is probably the mid and lower traps, the rhomboids, and the posterior. For the single leg squat assessment, we can see a little bit more. In both legs, pretty much the same problems going on. However, one leg definitely has magnified issues. There's just the left leg. We saw a lot more instability on that left leg. Once again, we see some eversion of the foot, leading us to believe we have tight calves, especially on that lateral gastrocs. We also see a hip drop of the leg that is the stance leg, and knee valgus at that same time, which is most likely due to adductors, as those two factors are occurring at the same time. So this is the left leg we see that mainly on, and this could be because she's compensating for that injury of her groin pull in her right leg, and through the connect chain linking, it compensates the left leg instead of having tight adductors. And as before, this is just leading us to believe that she has weak external rotators and the glute medius. It's pretty cool to see both these tests and how they aligned and what they agreed with their outputs and results.
Hello, my name is Noah Diaz de la Cuesta, and I was put on the dynamic postural assessment. So I made a little video here of the gait analysis, all 3 views. We can see that she looks a little stiff while she walks, and that we can kind of prove that that's a certain hip issue, which we already know it's the right hip. So you can see kind of femoral retroversion on that right side and anterior pelvic tilt on the lateral view. So some interventions that I came up with were strengthening the hip adductor complex, strengthening the internal rotators, and the stretching the external rotators to increase that range of motion on that leg. And for some anterior pelvic tilt interventions, we'd try and train the posterior pelvic region, so doing tilt exercises to kind of balance the both ends, which we can also increase some core exercises to increase that strength, and also do some lower back exercises to increase the lower back strength.
Lastly, as another assessment, we'll perform manual muscle testing to assess internal and external rotation of the hip. As you can see per the pictures, you'll place your hand above the ankle for the external rotation and under the ankle for the internal rotation. And the muscles that we're being tested for external rotation is the abductor complex, so the glute med, the glute min, and the TFL, as well as the glute max and the biceps femoris and the piriformis. And then for internal rotation strength, we're testing the adductors, So it's the adductor brevis, the adductor longus, and then also the gracilis, the pectineus, the semitendinosus, as well as the semimembranosus.